Hi everybody. Today's topic of discussion is musculoskeletal trauma, the series 8 in trauma series. I have no intention to teach you the entire orthopedics. So this is just we are reviewing the concepts of ATLS regarding musculoskeletal trauma. So why to learn extremity trauma in separate? So extremity trauma indicates a high velocity trauma. So pelvic fractures, some open fractures of the femur can even cause life-threatening bleeding. Even without a external wound, it can bleed inside the compartments and leading to life-threatening bleed. And severe extremity crush may cause rhabdomyolysis and acute kidney injury followed by the same. A fat embolism can be a lethal complication following long bone fracture, such as especially in the femur fracture, you can get fat embolism very easily. And priority never changes from ABCDE. So ATLS always follows airway, breathing, circulation, disability, and exposure. Even though there is a extremity trauma, we should see the ABCDE first. Then we need to look at the secondary survey and treat the fractures eventually. Let's see a missed scenario where the mechanism of injury is a 35-year-old male hit by a sedan moving in a 30 miles per hour speed while he was crossing the road. And primary impact at the knee and the secondary impact is head over the hood. So injury sustained, knee dislocation or fracture might be, and possible ligament injury can be there, and can be a head trauma or a chest and abdominal contusions as well. So signs and symptoms are knee deformity, observed as swelling, pain, and limited weight bearing and bruising, possibly a head injury signs also. And treatment given was he was taken to hospital after immobilization of the knee. Let's see what all injuries can be possible and how to treat this patient while coming to the hospital. The whole point of primary survey in trauma with musculoskeletal injury is to identify the potentially life-threatening extremity injuries. So any major arterial hemorrhage or bilateral femoral fractures or any crush syndrome is present, we have to identify them. And treatment includes the control of major hemorrhage by pressure, splinting of the fracture of the long bones, and appropriate fluid resuscitation. So regarding major arterial hemorrhage, it can be caused by the penetrating extremity trauma. The arterial disruption due to the penetrating trauma can be extremely notorious and to cause blood loss and shock. Traumatic amputation may require application of tunic to stop the bleeding. We'll see how to recognize a massive life-threatening bleeding. If it is a bright red bleeding, if it is pulsating and spurting out from a deep wound, then it can be massive and life-threatening. And on the other hand, this overlying cloth is ineffective and bandaging is becoming soaked with completely blood, then it can be a life-threatening bleed. And amputation with continuously oozing of the blood also can be life-threatening. So it's important to note that even as little time as 3 minutes is enough to cause a shock and cardiac arrest in a patient with massive life-threatening bleeding. So how to assess an injured extremity? Assess injured extremities for external bleeding, loss of previously palpable pulse and changes in the pulse quality, Doppler tone and angular brachial index. Ankle brachial index is determined by taking the systolic pressure value in the ankle of the injured leg and dividing it by the systolic pressure of the uninjured arm. Cold, pale, pulseless extremity indicates an interruption of arterial blood supply. A rapidly expanding hematoma suggests a significant vascular injury in the extremity. How to control the major bleeding? First method is manual pressure. Give a pressure with a dressing a stack of gauze or bandage over the area of the bleed and compress it with the palm at least for 5 to 10 minutes. Second method is to apply a tunic. Applying a tunic is like tying the tunic and rotating the rod to increase the pressure so that the major arterial supply to the limb is cut off. We can apply a second tunic if the first tunic is inefficient to control the bleeding. You should always mention the timing of application of the tunic so that prolonged tunicate application can be avoided. So regarding application of pneumatic tunics, a pneumatic tunic can be applied in the upper extremities with a pressure of 250 millimeters of mercury and in the lower extremities with a pressure of 400 millimeters of mercury. At the end of 1 hour, we can deflate and reinflate to achieve the blood supply to the limb. If it is a prolonged tunic, life versus limb decision has to be made. Because once the tunic is applied for more than 6 hours, there can be significant necrosis of the muscles as well as nerves, and it will be damaged so much so that it cannot be reversed. Let's look at some do's and don'ts of application of tunic and clamps. So vascular clamp application in an ED is per se not recommended, because if it is a deeper, larger vessel, if we are doing a clamp, then the vascularity of the limb will be severely compromised. If it is a superficial one, you can clearly identify the bleeder at the ED, then you can safely apply a vascular clamp. Then tunic application, whenever is done, the time should be noted and avoid prolonged application of the tunic whenever possible. If a extremity is severely mangled, that we know that it is not going to be replanted, or reconstruction is not possible, then a removal of the tunic is not recommended. Let's see regarding replantation surgeries. Replantation surgeries are usually done in isolated extremity injuries, and if the mangled extremity is there, then it is very difficult to replant the lost limb. So regarding preservation of amputated parts, so first we have to wash it thoroughly with isotonic saline. Either it can be saline or Ringel lactate we can use to thoroughly wash the amputated part and wrap it with a moist sterile gauze. And to keep that moisture, we have to cover it again with a moist sterile towel and wrap it in a plastic bag, and that plastic bag should be placed in a crushed ice bag, and that to be transported to the hospital. So you should take care that we should not put the amputated part directly in the ice. It will cause a freezing of the amputated part, which will reduce the viability of the amputated limb. This mistake has been noted in most of the time in pre-hospital care, where they directly put the amputated part in an ice pack and get it to the hospital and claim that it is viable. But it is really difficult to make them understand that this is not the way to preserve a limb. That's why I'm stressing on this point. Follow the exact steps which is shown in the figure so that you can have a viable limb reaching the hospital. Crush syndrome or traumatic rhabdomyolysis refers to the clinical effects of injured muscle. That is, if it is left untreated, can lead to acute renal failure and shock. This condition is seen in individuals who has a sustained compression injury to significant muscle mass, most often the thigh or calf muscle group. Let's see the pathophysiological mechanism of crush syndrome. When there is a crush injury, the intramuscular hemorrhage can happen, or it can be due to the direct traumatic impact or the ischemia reperfusion injury. It will lead to traumatic rhabdomyolysis. Myoglobin will be releasing from the muscle, and it will be reaching the kidney and causing kidney renal tubular damage. With that, it will cause some systemic manifestations also, including the hypotension. It can lead to shock, DIC, ARDS, hyperkalemia, hypocalcemia, infections, and along with that psychological problems also. One of the clue lab clinical tests we can get is urine will be amber colored and it will be having a creatine kinase of more than 10,000 units per liter. How to treat a crush syndrome? First and foremost treatment is intravenous fluid to prevent the renal failure. So if myoglobinuria happens, if rhabdomyolysis is happening, we have to target a urine output of 2 ml per kg per hour, and we have to give the fluids according to that. First of 1 liter of bolus followed by 1000 ml per hour for 2 to 4 hours, and then 500 ml per hour for next 6 to 24 hours. And alkalinization of the urine is another treatment which we can achieve by giving soda bicarbonate. Osmotic diuresis is also helpful treatment in crush syndrome. Detailed management of rhabdomyolysis is mentioned in our burns video. Check it out and like, share, subscribe. During the primary survey, if you find any major long bone is fractured, then we have to splint it and immobilize it. And immobilization will prevent the motion of the fracture site and reduces pain and control blood loss, and prevents a neurovascular injury and assess neurovascular status of extremity before and after manipulating and splinting if it is done. So open fractures and open joint injuries. Open fractures and open joint injuries result from communication between external environment and the bone and joint. You know that the bone is situated deep to the muscle and skin. So the muscle and skin should be injured to have an open fracture to occur. The extent of soft tissue damage along with the contamination makes it really difficult to treat an open fracture. Infection and delay in healing can occur in open fractures. What are the immediate care provided in an ED for an open fracture? We can pull the bone back to the wound and wash the wound, and antibiotic treatment can be started as early as possible. So how to treat an open fracture and what antibiotic has to be given? This question has been puzzling the orthopedicians and surgeons for a long time. In 1895, Dr. Boyd proposed that infection rate is proportional to the extent of the soft tissue involved along with the fracture. After that, in the 20th century, the gustilo has studied detailedly about open fractures and divided it into three groups according to the type. Type 1, Type 2 and Type 3. Type 1 is having skin loss of less than 1 centimeter and a clean wound. Type 2 with the skin wound more than 1 centimeter and soft tissue damage is not extensive and no flaps or avulsions. Type 3 is high energy injury with the multifragmentary fractures, severe crushes. And again, after some time, along with Mendoza and Williams, he has subdivided the class 3 into type 3A, type 3B and type 3C. Type 3A involving adequate soft tissue cover of the bone despite extensive soft tissue damage, and type 3B extensive soft tissue injury with periosteal stripping and bone exposure, and type 3C when open fracture with an arterial injury requiring repair is there. There is a tendency for ED physicians to probe if there is an open wound associated with a fracture. We should not do that because we don't know what structure is going to be exposed there. It can be an artery, it can be a nerve. So do not probe the wound. Regarding specific management of open fractures, you can give the wound wash and cover with the sterile dressing. IV antibiotics to be started immediately and TT immunization has to be given as early as possible. Sometimes a joint can be open along with the fractures. The presence of intra-articular gas in a CT of the affected extremity is highly sensitive and specific for identifying an open joint injury. In the absence of such findings, it is difficult to identify an open joint. In such cases, we can do a saline load test. A 10 ml of saline can be injected into the joint cavity and observe whether it is extravasating through the wound or not. If the loaded saline is coming out through the wound, then that is an open joint. Obviously, after the primary survey, we will go for ample history. While taking the ample history, we should keep the mechanism of injury in the mind. So, how to extract the maximum out of a mechanism of injury is using a Haddon matrix. Haddon matrix deals with the causes of pre-crash, crash and post-crash events, and it considers the factors of human factor, the vehicle or equipment factor and physical factor, as well as social and economic factors. Regarding history taking, the mechanism of injury, the environment the injury has occurred, and pre-injury status and predisposing factors, pre-hospital observation and care. These are the things we have to probe in the history. Let's quickly review the factors of mechanism of injury. It helps to identify the injuries that may not be immediately apparent. So, whether the patient has located before the crash, where the patient was patient is located after the crash, and what is the extent of the vehicle damage, if there is any fall, crash or explosion near the patient occurred during the crash. Regarding the environment, did the patient sustain an open fracture in a contaminated environment? Was the patient exposed to temperature extremes? Where there is any broken glass fragments which can injure the examiner also, and where there is any source of bacterial contamination such as dirt, animal feces or fresh or salt water to be inquired. And along with that, the ample history also to be collected. Regarding pre-hospital observations and care, the time of injury, the delay in extrication, delay in reaching the hospital, position in which the patient was found, en route treatments, time of tonic placement if applied, and pool of blood, any bone ends are exposed or not, obvious deformity, dislocation, absence of motor or sensory functions, immobilization during the transfer to the hospital, everything has to be collected. Regarding detailed evaluation of the limb, our main aim is to identify the life-threatening injuries, identify the limb-threatening injuries and conduct systematic review to avoid missing any injury. First about the look and ask. So visually assess the extremities for color and perfusion, wounds, deformity, swelling and bruising. A pale or white distal extremity is indicative of a lack of arterial blood flow. Any open wound to a limb is associated with a fracture should be considered as open fracture until proven otherwise. Questions regarding voluntary nerve function can be asked if the patient is conscious. Next, we should feel. Feel palpate for the extremities to determine the sensation of the skin and to identify whether there is any tenderness, swelling associated with the deformity, which indicates that bone fracture can be there. Do not attempt to elicit crepitus or demonstrate abnormal motion in suspected fractures. So, joint stability can be determined by the clinical examination. Abnormal motion through the joint segment is an indicative of tendon or ligament disruption. Next is circulatory evaluation. The importance of circulatory evaluation is that if the patient is in shock, we won't be able to identify the arterial injury as such. In such cases, Doppler can help us. Pallor, pulselessness and coolness of the limb can be there even in the shock also. Next is X-ray evaluation. If there is any fracture suspected, like deformity is there, swelling is there, crepitus is there, we should take a X-ray to diagnose it. So only condition where we delay an X-ray is the vascular compromise. If there is vascular compromise, we should reduce the fracture or the dislocation and then only attempt for an X-ray. Regarding the treatment of closed fractures, the fracture is defined as a break in the continuity of the bone cortex. There are signs like pain, swelling, deformity, tenderness, crepitus, and abnormal motions. Assess the neurovascular status if there is a fracture. X-ray should be taken in both the perpendicular planes, right angle to each other, so that we can identify the cracks in the cortex. And to exclude the occult dislocation and concomitant injury, X-ray films must include the joint above and joint below. Treatment of closed fracture is immobilization and pain control. So, the femur fractures, the traction splint, unless the tibia is also fractured, we can put a traction splint. And a pre-hospital setting, we can use the binding of the injured leg to the other as a splinting. And knee injuries, the posterior long leg plaster splint or knee immobilizer can be used. Keep a 10-degree flexion in the knee injuries to reduce the tension of the muscles. And tibia fractures, plaster splints immobilizing the thigh, knee and ankle can be used. Joint and ligament injuries, there can be limb threatening injuries. The signs are tenderness, hemarthrosis and passive ligamentous testing might be positive. And management is immobilize the joint and serial reassessment can be done. In case of contusions and lacerations, laceration we can do the debridement and closure. If it enters deep inside the fascia, it might require operative intervention. So, involve a surgeon if it is involving deep into the fascia. And the contusion, you can use a cold pack application, you can take rest and rule out internal degloving and crush injuries in case of contusions and lacerations. There can be minimal signs above the skin such as abrasions and contusions, but deep inside there can be moral level lesions or large hematomas or degloving injuries can be possible. So, rule out those possibilities when we are treating a contusion or laceration. Neurovascular injury can be another dreaded complication of fractures. So, neurological injury can occur due to a fracture or dislocation. For example, sciatic nerve compression can occur from the posterior hip dislocations. Axillary nerve compression can occur from anterior shoulder dislocations. Assess the motor and sensory function in secondary survey to diagnose a neurological injury. Another complication is vascular injury. Blunt, crushing, twisting or penetrating injury or dislocation in an extremity can cause vascular injuries. The cool extremity with the prolonged capillary refill time and distal part of the extremity, diminished peripheral pulsations and abnormal ankle brachial index are the signs of vascular injury. Caution, muscle necrosis begins even when there is a lack of arterial blood flow for more than 6 hours. So, time dependent conditions are these. So, CT angiography is a diagnostic modality of choice and early operative revascularization is the treatment. Finally, compartment syndrome. The pressures when it is greater than 30 millimeters of mercury, the compartment syndrome can occur inside a compartment. So, causes can be increased pressure inside the compartment which can be due to an increase in compartment content like bleeding inside the compartment or decrease in the compartment size as a constrictive dressing. So, compartment syndrome is a clinical diagnosis. Pressure measurements can only be an adjunct for its diagnosis. This is a very important point you have to remember. And the absence of palpable distal pulse is an uncommon and late finding and it is not necessary to diagnose a compartment syndrome. So, do not wait for the pulse to go disappear and your patient will disappear after that. So, promptly release all the constrictive dressings, casts, splints and immediately obtain a surgical consultation if you suspect a compartment syndrome. See you with the upcoming video. Trauma Series 7 Spinal Cord Injury. Stay tuned.